Yeah, first of all, I'm very happy to be here again, and this is my second time here in Bulgaria, and I thank the organizing committee for having me in front of such a distinguished audience, and I especially thank Ivo also for inviting me here. So my topic is an update on drug-coated balloon and FEMPOP interventions. Our aim in FEMPOP intervention is to revascularize the limb with the most efficient techniques and stabilize the region with durable, long-lasting solutions. This is our case example, diabetic patient with a critical limb ischemia Rutherford 6. The angiogram shows us only a profunda SFA proximal cap is ambiguous. Indication for intervention is clear. And here is my scientific evidence for this intervention. This recent paper confirms that DCB angioplasty is associated with high procedural success comparable to that of bypass surgery. This review states also an endovascular first strategy should be recommended. Here is our case again. With an educated guess, we tried a contralateral antegrade approach, and this is a band catheter, Gaia PV 018. 018 wire went into the true lumen, and tip injection, we are in the true lumen. Why isn't this moving? This should be moving. The second picture. Can someone help me, please? There is a below the knee injection there. So this is the one, okay. It should be moving, okay. Then changing with a treasury propy wire, we end the true lumen. And here, first balloon dilation, okay, with a plain balloon. And then comes the question, should we further ballooning with a drug-coated balloon? The scientific evidence says yes. You see here a lot of randomized studies and their forest plots for DCB versus plain balloon. Both target vessel revascularization and 1-year patency rates are in favor of drug-coated balloon. Even the 2-year results are better with drug-coated balloon, contradicts the idea of a catch-up phenomenon, which we can see about 12 and 44 months. Here are some data from the famous impact studies. Superior outcomes with drug-coated balloons compared to plain balloon in 3 and 5 years follow-up. DCB is also very effective in CTOs. So our patient had diabetes, this patient, and the subgroup analysis of diabetic patients in the ECHO-ART study showed significantly lower 6-month late lumen loss in the DCB group versus plain balloon, suggesting an efficacy of drug-coated balloons even in diabetic patients. This data was also confirmed in a recent meta-analysis led by Karadu et al. If there is a state-of-the-art therapy, then I would suggest this result here, leaving nothing behind, no stent, profunda is intact, no flow-limiting dissection, an optimal SFA treatment result for this patient. And DCB, okay, but which one? There is no head-to-head comparisons between DCBs. All currently use dry-state paclitaxel, but differences in drug concentration. Importantly, the Karadu meta-analysis reported that the dose of paclitaxel is related to the magnitude of the treatment effect. Predilation is considered an integral part of the procedure to avoid drug loss during crossing and to ensure an equal distribution of the drug across the vessel surface. A cautious approach with a balloon 1 millimeter diameter smaller than the size of the target artery is generally recommended. Only registries from Mikari demanded a predilation time over 120 seconds. In my practice, it is 1 minute to prevent any beforehand dissection. So the inflation time recommended for optimal drug release is between 30 and 60 seconds, and it was mostly over 100 in randomized controlled trials and in global registries. Few data are available regarding transit time, and only Levant 1 and Levant 2 studies recommended a transit time below 180 seconds. And the pressure in the Levant 2 was 9.5 millimeter. Here's another example. We have an aortic dissection in the distal part of the aorta and an iliac aneurysm on the right and a total occlusion on the left SFA. We didn't want to complicate the procedure, so we have chosen the ipsilateral antegrade approach. A long floppy wire from the radial artery acted as a roadmap, and an ipsilateral antegrade puncture was done. We see here a total occlusion of the mid-distal SFA after inserting a short sheetless catheter and 35 microcatheter. This short calcified lesion was crossed with an Gaia PV or 18 intraplaque, and I don't have this fluoro storage, so I couldn't show you how we crossed the lesion, but predilation with a 5 by 150 millimeter balloon, which was 1 millimeter less than the actual vessel diameter. There is a dissection and a cracked lesion with a residual calcium here. It is not moving again. This should be moving. Okay. No, not this one. I am waiting. You can't see the cracked calcium. Okay. Okay. Never mind. And after 5 minutes of DCB inflation, here is the end result. One should always check below the arteries after a SFA intervention. I left nothing behind and kept the artery open. And I would love to end my presentation with this nice result, however I can't, because a lot of operators in my country refrain from using drug-coated balloons since 2018, despite multiple randomized trials. And here comes the reason why not. Because in 2018, Katsanos published a meta-analysis indicating a higher incidence of mortality with paclitaxel usage. Prior to these studies, this publication, the body of evidence suggested that DCBs are safe and maintain a positive clinical benefit in the treatment of FEMPOP disease, as reported in the SKY consensus guideline and in the ACC AHA report. Two main conclusions were drawn from this meta-analysis. First, a higher mortality incidence with paclitaxel DCB, which was ascribed directly to paclitaxel. Second, the risk of death beyond 1 year is significantly higher with higher dose of paclitaxel devices. So, however, since then, a lot of studies indicating the shortcomings of this meta-analysis and pointing to the opposite direction. The objections can be summarized as authors had no access to patient-level data and provide no explanation for paclitaxel-associated mortality. Time to event analysis was criticized along with the fact that in one arm of the study, 40% of the patients needed a silver PTX stent. 1 year after this paper from Katsanos, more robust data come into light from Peter Schneider, indicating no association between paclitaxel and mortality up to 5 years. There was no correlation between overall survival and mean paclitaxel exposure. More importantly, paclitaxel was not one of the mortality predictors. Here's an analysis coming from JAMA with over 16,000 patients treated across various US centers, shows no evidence of increased all-cause mortality following FEMPOP DCB intervention through 600 days post-procedure. Here's another cohort study. Okay, I had a laser, and I find out now. Okay, and here's another cohort study published in the ECG paclitaxel. Coating was not associated with long-term mortality for up to 11 years post-DCB application. This is another paper in this propensity score matched analysis, retrospective analysis. It has been clearly pointed out that no mortality increase with DCBs. And here comes the last, but the most important one. And in this VDPAT randomized trial, no mortality was associated with paclitaxel up to 4 years. In summary, an endovascular first approach is usually recommended in FEMPOP-occlusive disease, and by doing that, we should stick to our DCB policy as it was before 2018. And we have abundance of positive scientific evidence regarding the benefit and safety of DCB usage. Thank you for your attention.
Thank you, Sevket. It was really very, very interesting and evidence-based presentation. I would say that for all of us, our community, it was very important to make the exact revival of the drug-eluting balloon technology after, you know, the signal of about increased mortality. But fortunately, like often in the medicine, after looking back on the real data, we saw that in fact the devil is not so bad. Yeah. And fortunately, again, we have on the shelf the drug-eluting balloon, and we are using properly in all the cases, especially in diabetics, like you showed the first case. It's very important in order to prevent restenosis. We know that restenosis is not a neglectable rate in peripheral vascular interventions. So this is crucial. This is crucial for us.
Yeah.
Thank you.
Yeah. Okay. Yeah. Doing a lot of SFA cases, the motto is leave nothing behind, because if you leave something behind, you will end up with some kind of restenosis and with reintervention, and sometimes you will not manage to going to the stent and salvage the vessel as you want to have. So I think we have still a way to go with the SFAs. Maybe they will invent some scaffolding with drug eluting scaffolds, and I think that would be the solution for this problem, because with stents we have restenosis, but if you have a scaffold there, that would be gone after 1 or 2 months with drug coating. So I think that will be the solution, I think.
Thank you.
Yeah.